So more about our mission and impact. AAPCHO is dedicated to promoting advocacy, collaboration, and leadership. Again, we focus on the health status and access of Asian Americans, Native Hawaiians, and Pacific Islanders within the U.S. territories, and the freely associated states. So all of the areas here that are indicated in that kind of burnt orange color are where our members are located. And currently our members are all over and continue to, engage and increase in as we continue to focus on promoting the support for these communities. I'm going to talk a little bit more about the TB Elimination Alliance, and so next slide, please. The TB Elimination Alliance is actually modeled after Hep B United, and a lot of what we've learned from just the success of Hep B United and how you all have put together your coalition work, brought together your mini grant program, and the ways that you all have just been so culturally responsive and dedicated to your communities is really, I think, what inspired us to model a lot of the efforts and the way that the TB Elimination Alliance works. So TB Elimination Alliance is a national partnership and of community leaders dedicated to eliminating tuberculosis and latent TB infection in communities that are at risk for TB. And so we're made up of 4 leading organizations, and that's AAPCHO, Asian Pacific Islander American Health Forum, the Hepatitis B Foundation, and Stop TB USA. And we started in 2019 and still going strong. And I can share more about our mission. Next slide. So our mission of the T Alliance, again, I think just what I shared earlier about being a national partnership, we're also focusing on these pillars of education, raising awareness, and innovation. And our vision is really uplifting healthy communities free of tuberculosis. So I'll pass it forward to Frank and to share more about Hep B 101, and then I'll go into TB 101.
Thank you, Chivo. So if for those of you who joined the Hep B United webinar about a month ago on the basics of Hep B, there will be some overlap, but we really did want to have this framing about hepatitis B through more of a tuberculosis lens. So you won't see that many repeated slides. So hepatitis B is one of 5 hepatitides, and it is a bloodborne hepatitide. So it can be just an open wound on you, and then infected blood kind of entering into it, either directly from someone or pass through another object. It is preventable through vaccine. There are 2 and 3 dose options, and they can be, in fact, the standard is here in the US is that a vaccine dose is delivered within 24 hours of birth. So we really are focused on preventing this. Hepatitis as a disease has the ability to be acute. And so for Hep B, we do see quite a few folks who acquire hepatitis B and then their body resolves it on its own. Their infection is less than 6 months, and then the immune system kind of fights it off, and it builds a natural immunity. But that is not everyone. And we still have tens of thousands of cases a year that become chronic or identified as chronic. And once you have hepatitis B and that is chronic, it can now start progressing. Right now, we don't have a cure, not a set of pill that you can take and just be rid of the disease. Other hepatitis have that, but hepatitis B is not one of them. But similar to HIV, you can take a lifelong antiviral or a long-term antiviral to bring your viral load down to 0 or undetectable. And when you are undetectable, you're untransmittable. So you can, through treatment, bring your disease state down to such a low level that you are now unable to transmit the virus to others. As I said, we have tens of thousands of new cases every year of newly reported chronic cases. So our most recent data in 23 put that number at over 17,000 just in the US. And then in terms of new acute cases, so these are cases that were initially identified. There isn't a second test to show that it could be a chronic infection. 14,000 cases we're still looking at, and 23 is the last time we have data. We have seen a smoothing out or a plateau of the number of new cases in the US since actually the COVID year, 2020. Some of that could be underreporting or just a disruption in the testing, and some of it could also be success in driving more prevention, both around adults and children, as well as getting more education out there about how to not transmit the disease within at-risk communities. The prevalence in the US, because this is an undetectable disease in a lot of ways, not undetectable. I mean, it presents with few side effects, and so often folks are living with the disease and don't realize it. So prevalences range from the CDC estimate of just under 900,000 to an estimate that we wrote a journal article around and have is based in strong scientific numbers of closer to 2.4 million. The key difference is when we did our research at the foundation, it was looking also at foreign-born individuals in the United States, because disease does not really care if you were born here or elsewhere when it is deciding to transmit among two individuals in close contact. Part of the reason we are been so focused on prevention in B is because a quarter of the cases can progress into liver cancer and cirrhosis, and those have really significantly negative health outcomes. Hepatitis B is also a little bit unique among the hepatitides in that it can skip the cirrhosis phase. So normally you see a liver kind of progressively scar through different fibrosis staging and then move into liver cancer, and it is possible that the liver kind of just skips the scarring phase, and that makes it a bit scary. And because there are no side effects, about 2/3 of individuals in the US are unaware of their status. For being one of the most widespread global infectious diseases, this still is a really high number, because we think that if anyone's at risk for it or everyone's at risk for it, we should be checking everyone for it, and really the healthcare systems haven't caught up to that yet. It's also concerning because hepatitis B allows for a co-condition with hepatitis delta, and that sort of co-infection can have also significantly bad health outcomes. And as I mentioned earlier, we have a vaccine. We've really been pushing it, especially since 1990. And so as a result, we see lower rates in children and adolescents than we do in older adults. And the next slide. I mentioned earlier about how hepatitis B can lead to liver cancer. A lot of our focus, people think about hepatitis as a kind of a standalone thing, but it really needs to be thought about as the precursor to liver cancer. So getting a vaccine for hepatitis B means you're preventing something that leads to liver cancer. You're preventing liver cancer. And that is not only just for messaging, but that is just correct in the medical epidemiology of it. Untreated, left to its own devices, chronic Hep B has worse health outcomes than it does when it's treated. And saying cancer just because cancer is a scary word is not what we're doing. These numbers are a little bit older, and current numbers are actually a little bit scarier, but it remains one of the top 10 deadliest cancers in the United States, and specifically looking at the communities impacted the most by hepatitis B, like Africa or Asian immigrant, Asian American, Native Hawaiian, Pacific Islanders, that where it's at on their list of deadliest cancers is even higher. And then with that, I'm going to turn it over to Chibo to talk some about TB.
Thanks so much, Frank. And thank you for just going into detail over Hep B and just sort of the progression and just things to be aware of. Unlike Hep B, TB is a curable disease, but there are a lot of similarities in terms of the populations and communities that are at risk for both TB and Hep B. So TB is spread from person to person through the air. It is a disease caused by bacteria. It's known as the Mycobacterium tuberculosis. The bacteria or TB germs usually attack the lungs. However, TB germs can attack any part of the body, such as the kidney, spine, or brain. Pulmonary TB is TB in the lungs. Extrapulmonary TB is TB in places other than the lungs, such as a kidney, spine, or brain. And not everyone infected with TB germs becomes sick. I think a lot of folks think of TB as a disease of the past, but it's very much prevalent today. It is the most infectious, deadliest disease, one of them, and too many people in the United States still suffer from TB. There's about 10.8 million cases that were reported in 2023. We actually have the 24 data out too, and it looks like cases have not have just continued to increase and kind of stay the same level as 2023. And TB is a serious disease that can cause, a person to become very sick if they're not treated with the right kind of medicine. It's also a unique disease that takes a well-rounded approach, a holistic approach to really dismantling and eliminating it. And so treatments are available to prevent and cure TB. And I just wanted to also preface before I share more about TB that all of the information that I'm sharing here is actually directly from the CDC's website. My colleague, if they haven't shared already, they can, Dia or Rihanna from our T team can add the link to the slide set that I'll be sharing today from the CDC. And there are many resources for providers and also resources for individuals that I highly encourage you all to check out. And I'll keep on uplifting those resources because it's very useful. Okay, next slide. I think we're going to go into a little bit more about the care cascade. Yes. Okay.
Yeah, we'll pop back and forth. And thank you for that note about CDC. Similar here, most of the data I present will be from CDC. Where it's not, it will be from us, but we are a scientific organization and are often a source for the CDC. So, but if there's any questions about any of the data, feel free to ask. This right here is really showing not only the number of chronic Hep B infections, and this is an older chart, showing the difference is a low estimate versus a high estimate, then into how many know of their infection, how many are potentially eligible for treatment. And so that could be they aren't, their viral load isn't changing. It's already, they have the disease, but it's low, and there might be other side effect considerations for the treatment, so they're not starting medications. Then you have the number of folks entering into care, and so this is where because hepatitis B is a lifelong disease, it is not curative. You have to go and keep an eye on it year over year, and you could skip a year or two and sort of fall off the chart. And then this 50,000 annual prescriptions would be higher now, but it really just showing that the number of people living with the disease versus the number on actual medication is quite a gap. And all along those steps, there are bad reasons, barriers to accessing those steps that is causing the drop off. And then next slide. Similar to what, so I think both Hep B and TB, you have to figure out, is it acute? Is it chronic? Have you had a vaccine? Have you been tested? What sort of treatment have you been on? This is a clinical workflow showing what a medical provider would have to go through when determining whether or not someone should get a screening or vaccine for hepatitis B. And I'm not going to go in through it step by step, but you can just sort of tell that given that you have like sort of 6 different outcomes and ways to get there, you really do have to be well versed in multiple different areas of the disease in order to be well versed in it at all. And that in itself is a barrier to getting more clinicians and community folks to understand and kind of tackle this, because it is a complex beast, and so is TB. And then I think we're going to see the TB LTBI care cascade next.
Yeah, thanks, Frank. The care cascade of TB is quite complex as well. It's it represents this map here, or this kind of chart, care cascade, represents 8 distinct steps from initial TB screening through to treatment for latent TB infection. So where you see the indicator of the 28.1, the 5.9, the negative 10%, These show that losses may occur at each step in the cascade, and there's 4 important steps in that where the majority of losses, and these losses are patients who would we would lose to follow up for treatment. And so those losses occur at initial screening, completing medical evaluation, starting treatment, and completing treatment. And just wanted to share this as an example of what a care cascade looks like, for the importance of making sure that we're screening those that are at risk. You know, that from there, similar to Hep B in some ways, that we're, you know, testing, then we're kind of identifying what is the best course of treatment, and then from there, how can we, you know, use this approach to reduce preventable losses in the cascade. I wanted to also share another example of a TB care cascade, and this is for latent TB infection as well. This is from the provider perspective. Next slide. And it's a wonderful tool that I highly recommend from the California Department of Public Health. They put together collectively through many other providers and clinicians and community health centers and CBOs, the Preventing TB in Your Clinical Setting Guidebook. And so this shows the steps in the care cascade of how to assess patients that are at risk for TB infection. They also have in there ways to assess risk and kind of a guide, an approach for how to assess that risk, how to test for TB infection, IGRA preferred, how to document positive tests for TB infection, evaluating patients for TB disease, including chest X-rays, and then completing chest X-ray and documenting normal results. And then whether we should prescribe LTBI treatment, and then how to make sure that you're retaining that patient in care, you're following up with them, and you're documenting treatment completion and supporting them in that care cascade. Okay, looking into transmission, I'll bring it to Frank to share more about Hep B transmission.
Yeah. So as I mentioned earlier, this disease, because it's bloodborne, requires direct contact with infected blood. Globally, the most common transmission vector where this occurs is to a newborn child during birth, and then their mom has the disease. And unfortunately, infants exposed in this way have a 90% chance of developing a chronic infection for B. And I say this globally because most of the world is kind of in that boat. The US has a gold standard system of perinatal prevention for B. And so we have shown it is possible through testing the mother, as well as a prophylaxis dose of something called HBV to the infant right at birth, has a great chance to actually prevent that Hep B transmission. And so we're able to have babies born here to untreated and mothers living with hepatitis B that don't pass their disease on to their kids. So we can prevent this on a global scale with the right resources. But that is not the only way. It can also be transmitted via sex. And in fact, most people assume that's how it happens. And in fact, that is not the risk factor for much of the transmission for B, even here in the US. We also see it through contaminated or unsterile medical or injection equipment. Drug use, not even sharing needles, but sharing like cookers or other paraphernalia, even snorters or pipes, is a transmission vector we're seeing here in the US. And it's not just that, it's other unsterile tattooing and anything else really where blood can be drawn. The next slide. I made a comment earlier about how the disease progresses and how it's unique in that it can go straight to liver cancer. I just wanted to point here, because I think this is a good visual layout for those who may not understand liver disease progression, of kind of how things move along. And so again, just when we're talking about hepatitis B and hep chronic infection, that's only one little box, but we really are worried about that box, worried about not getting to that box because with prevention, and then also trying to make sure we don't ever leave that box. We don't go into cancer, cirrhosis, failure, transplant, or death. All right, how's TB progress? How does TB progress, Chibo?
Yeah, thanks. Thanks, Frank. I was reminded. So last year, I had two baby girls. I had twins, and I was so pleased with the health system for just like providing like the Hep B vaccine, and like just to me as a mom, but also like recently we had to travel, and so they also were like, okay, like let's look at the countries that you're traveling to, and for my daughters who are now 10 months old, they also gave the girls Hep B vaccine. So it's just I'm appreciative of the health system to hear that can help provide that to my daughters and to and so just a great reminder for me of like just making that connection too, and but also understanding where the challenges are. So TB transmission is different. TB spreads through the air, and it can spread from person to person when someone with active TB disease coughs, speaks, or sings. I actually didn't I didn't notice that. I didn't think about the singing part. And so that's actually quite interesting. And but for TB transmission, it's a little bit different. It's definitely a lot different. It's not spread in the same ways at all. And so next slide, please. So TB is not spread by sharing toothbrushes, saliva from kissing, shaking someone's hand, touching bed linens or toilets, or sharing food, drink, or utensils. It is TB, and next slide, has two related conditions. So TB is, there's inactive TB, also known as latent TB. So people with latent TB infection or inactive TB, they do not feel sick, they don't have symptoms, and they cannot spread TB germs to others. Folks who have inactive TB or latent TB can be inactive for years, and they have a small amount of TB germs in their bodies that are alive but inactive, and it can develop and progress into TB disease. So for TB disease, if TB germs become active and multiply, inactive TB can turn into TB disease. And I know this sounds a little bit complicated, but I wanted to make sure that there's a note about the inactive TB and TB disease and the TB disease, because what I'm gonna share next is a little bit more about the inactive TB. Next slide, please. So one thing to note about the progression of untreated inactive TB is that it can lead to TB disease. If the immune system can't stop TB germs from growing, they become active, they multiply in your body. This is called TB disease. Most people diagnosed with TB in the United States become sick after living with inactive TB for years. It is estimated that up to 13 million people in the US have inactive TB, and latent TB treatment is 90% effective in preventing the development of TB disease. Next slide. So I'm sharing with you here this graphic, and I want to be able to just share that it helps to summarize TB disease and inactive TB in the United States. I'll go into this a little bit further. TB is just the tip of the iceberg. So that's what you're viewing at the top. And it is visible and above the water. TB disease can be seen because of the active germs in a person's body and the symptoms they experience. People with TB disease can spread TB to others. However, the larger part of that iceberg that is hidden underwater represents inactive TB. So like the iceberg, inactive TB can be easily hidden because TB germs are inactive. And people with inactive TB germs are do not feel sick. So many people with inactive TB do not know they are infected with TB. There are up to 13 million people in the US with inactive TB. So without any treatment, this can develop into TB disease. And so who is impacted by TB, and who is impacted by hepatitis B? These communities are interestingly, similar communities. So I'll bring it to Frank to share the next slide on our health disparities.
I love that iceberg reference, because we too in the B space, feel that way. Like the tip of our iceberg that's above the water with the symptoms tends to be cirrhosis and liver cancer, but we're so focused on what's below the water because it's the folks don't realize they have the disease, and it's the area of like what we need to focus on to prevent further things from occurring. Unfortunately for both hepatitis B and tuberculosis, there are health disparities of who is impacted by the disease here in the US. So this slide does not cover, it is one slide, and we could have spent 50 slides talking about the health disparities of these two diseases. So just know that I just want to say out, like, I recognize this slide does not do the disparities and inequities in this disease justice. We are seeing some of the biggest disparities among the Asian American, Native Hawaiian, and Pacific Islander community. So less than 6% of the population, but more than 60% of all chronic cases. And that is not because of over-testing. That is just a real disparity. We are also seeing African immigrants with high infection rates. And that number, that community has been growing as that community in the US grows as well. We have had a much greater focus on people who use drugs, especially injection drug users, but really all drug users, because we are seeing that is a rising risk factor. And then there are others that we are concerned about when it comes to hepatitis B, because they are living with or at risk for a different disease, HIV, Hep C, just because if you are having a co-infection of B and one of those diseases, or a tri-infection of all three, it's just a really tough health outcome to get over. And then kidney disease and diabetes, hepatitis B and their treatments can be really toxic to the kidney and renal system. So really just something else that getting a positive health outcome with this, it can be concerning. But we talk about these risk factors, but I think it's really important to note that everyone can be at risk for either of these diseases at any point in their lifetime if they leave the house. Like if you leave the house and you see other people in the world, you can be at risk for both of these. And so it's good to know about them and make sure others know about them. Next slide. We're back to Chibo. Yeah. Who can get TB, Chibo?
Anyone. So anyone can get TB. And I am sharing here that some people have a higher risk of getting infected with TB. People who have contact with someone who has infectious TB disease, people who were born in or who frequently travel to countries where TB disease is common, including some countries in Asia, Africa, or Latin America, healthcare workers, and others who work or live in places at high risk for TB transmission, such as homeless shelters, jails, and nursing homes. And others at higher risk include employees of high-risk congregate settings, healthcare workers who serve patients with TB disease, populations defined locally as having an increased incidence of inactive TB or TB disease, including medically underserved populations, low-income populations, or people who use drugs or alcohol, and infants and children and adolescents. So definitely in that sense, there are, a lot of similarities in terms of the health disparities that both TB and Hep B impacts, the impacts of the health disparities of TB and Hep B. Next slide. So I wanted to go into detail about, again, TB impacts people from all over the US. This is a great shot of some of our partners from We Are TB, which is a wonderful organization that supports survivors of and patients of tuberculosis. So TB is still a life-threatening problem in this country. As we know, as we're learning, it's impacting people across the United States. And anyone can get TB. I think one thing that's just really critical is that there are organizations that have been doing such phenomenal work around, tackling TB, and I'm just uplifting We Are TB here and the Hep B United, having coalition partners like Hep B United and the work that we're doing in TB Elimination Alliance, along with the National TB Coalition of America. It really allows for I would say dynamic approach for eliminating and for really focusing on these tuberculosis efforts. I'm going to go share more about why we have these great coalitions that are supporting a lot of these impacted communities of TB. So this slide, next slide, shows that TB disease in the United States is most common among people who were born in countries with high rates of TB. So there are demographic characteristics of TB patients that have remained fairly consistent over the last several years. So for example, since 2010, the majority of reported TB disease cases in the US occur among non-US born persons. So what I'm sharing here is from 2023 and sharing with you the percentage of those that are from that data point. And then on the next slide, as seen on the previous slide, TB disease in the United States is most common among people who are born in countries outside the US. This next slide, if you can go to the next one, it shows specifically is most common among, it shows the countries where there are high rates of tuberculosis. So this pie chart shows the most common countries of birth among non-US born persons of TB disease. Most common countries of birth are among non-US born TB patients, and they've remained pretty consistent over the last several years. So it shows data showing that Mexico and Philippines and India, Vietnam and China and other countries are represented in the 52% of cases. So this is just something to, I think, outline the importance of just having, of why it's important to really consider all of the impacted communities that are, faced with challenges of TB and active TB. So going back again, who is at risk for developing TB disease? The next slide. So I think this chart here, I highly recommend you all to utilize and repurpose for education. It's really helpful to show that people at higher risk for developing TB disease, they generally fall into two categories: those who have been recently infected with the TB germs and those with medical conditions that weaken the immune system. And this is critical, I think, to show really the different kinds of chronic diseases that can also impact and be at risk for TB as well. Next slide. I'll bring it back to Frank to share more about some of our Hep B screening.
Yeah. So as I've said multiple times, the people don't realize they have Hep B. 2/3 of folks living in the US don't realize they have Hep B. Sorry, 2/3 of those living with Hep B in the US are not aware they are living with it. The accurate way to say that. And because we aren't able to say like, oh, if you have this symptom, go get tested, because most folks are asymptomatic, it really does require just everyone needs to get tested at least once. And so finally, after years of advocacy, that is where we are at in the United States. If you are 18 or older, you need to make sure at least once in your life you have a hepatitis B test. And that is the US public health version of just trying to catch everyone who might be living with the disease. Beyond that, though, there is the recommendation of more frequent testing, like annual testing, if you have an ongoing risk factor. So you are living with one of the co-conditions I mentioned earlier, you are partaking in risky behavior like drug use or unprotected sex, then you should go get tested more often because your likelihood of acquiring the disease is higher. But we do have the recommendation from the US Public Health groups is that everyone should get tested at least once. So go in, ask your doctor if you aren't tested, and if you have the ability to test others, make sure they know that as well. And the next slide. So this next slide is complicated, and that is why I am so thrilled we have a universal screening recommendation, because in order to fully identify the situation of a person's situation with hepatitis B, it actually requires 3 different tests. All of them blood draw, so you can just do the one blood draw, but you run these 3 different tests. And depending on what these 3 tests say, like yes or no, and then you look through this chart, you're able to have your patient or someone's able to be kind of put into a category of is not vaccinated and is at risk for the disease, has not been vaccinated but has natural immunity, is currently living with the disease. I should have just read it off the list. And then, yeah, so it's really, are they immune or not? And if they are immune, how do they get that immunity? Is it through a vaccination or a natural immunity? And part of why having that answer is important is for the same reason why having the answer around latent and non-latent TB is important. You can go on to a treatment like a autoimmune treatment, or even actually like one of the GLP-1s, like the Wegovy's. If you listen to the commercial that comes on every 30 seconds, they say you know make sure you do not have tuberculosis or hepatitis B, and the reason why is that because it's impacting the immune system, it can take an untreated chronic B infection or like a latent TB infection and exacerbate it into its kind of down the road form. Next slide. I wonder if TB is complicated to test for.
So with TB, there are 2 types of tests that can be used to diagnose TB infection. But before testing, as I shared before, those risk factors are really important. There's also a risk assessment tool that is very useful that many providers and clinicians can use to be able to assess a patient for whether they are at risk for TB, and then and that is part of the screening method. One thing that I forgot to note is just some of the great work that's coming out of California. The Coalition for TB-Free California helped to really facilitate and lead the Assembly Bill 2132, which is now law, which is based actually off of a Hep B on Hep B screening recommendation. And so there is now a California screening recommendation for providers, and make sure that it's definitely something that is mandated for them to be able to screen and make sure that each patient has is going through that kind of assessment. And so the 2 types of tests that can be used to diagnose TB infection are TB blood tests or a TB skin test. So if either test is positive, it can lead, then there needs to be further tests that are done to confirm a diagnosis of TB disease. So there's a medical examination and then a chest x-ray. And these next few slides, again, they're available on the CDC website, and you can repurpose them for educational purposes as well. Next slide. So TB blood tests are preferred for people who have, next slide. They are preferred for people who have received the TB vaccine, also known as BCG. So the TB vaccine may cause a positive TB skin test, and the TB vaccine does not affect TB blood test results. TB blood tests give more accurate results in people who have received the TB vaccine, and anyone who has received the vaccine should receive a TB blood test instead of a TB skin test. The TB skin test, next slide. So the TB skin test, also called the Mantotuberculin skin test, TST, requires 2 visits with a healthcare provider. So on the first visit, a test is placed, and then on the second visit, the test is read. How is hepatitis B treated after we go from the testing into the treatment?
Yeah. And I will note we got a question in the midst from the chat, and I didn't see till now. There was a question around congregate settings being a risk factor. Yes, justice-involved individuals should be periodically screened, but anyone who wants a test can ask for it. Actually, that's part of the recommendation. So if you are in a scenario where you think there could be potential exposure on the Hep B front, your ability to walk in and ask a provider for a test and then have it be covered preventive service, that should still exist. And then around Hep B treatment, and I think this is my last slide. There are two categories of treatment. The first one, immune modulator drugs, are they're interferon type drugs, and they are generally not gone to anymore. Over the last decade plus, we have really gotten, or really 2 decades, have gotten a much better kind of pill-based treatments that don't require the chemo-esque side effects of those interferon type drugs. But it is important to know that some folks who are familiar with hepatitis B might have gained that knowledge back in the interferon days, and so it's important to know, like, that's what that was. Now we have antiviral drugs. And these antiviral drugs are very similar to other antiviral drugs, particularly the HIV antiviral drugs. Essentially, lifelong treatment, but it helps bring down that viral load. It's unable to completely cure or take away the disease, but it is able to bring that disease state down, which allows you to then not be able to transmit it. And then this last note, this isn't a disease where if you have it, you should be on treatment, because once you start treatment, you need to stay on treatment. If you come on and off, you can then gain a resistance to treatment, and that makes it harder to start a treatment in the future. And so really a provider using a set of guidelines will look at if your viral load's high enough, if you have other risk factors, where your kind of general health is, and maybe make the determination of, like, you know what, let's not try to add anything to your system. Let's just see if we can keep this viral load at this low point already naturally and not intervene it. And so treatment is not necessarily always the goal, but care is. We want to make sure, even if you're not taking a pill, that you at least have access to the testing and the provider as often as you need to in order to keep that disease in check. And I'm going to hand it over to Chivo and learn about this piece of.
All right. Thanks, Frank. So treatment for inactive TB. So compared to treatment for TB disease, inactive TB treatment is usually shorter, it's less costly, and has fewer side effects. Next slide. It can prevent the development of TB disease. So people with inactive TB will not feel sick. As long as TB germs remain in the body, they can become active, multiply, and make someone sick with TB disease. But people with inactive TB should take medicine to prevent the development of TB disease, even if they don't feel sick or have any symptoms. Next slide. So just sharing, some of the reasons why it's important for people to treat TB disease. You can pass it to your family. It's highly infectious, so they don't take TB medicine right away. People with TB disease need to take several medicines when they start treatment. And after taking TB medicine, a doctor will be able to tell TB patients when they are no longer able to spread TB germs to others. So there is a period of isolation that is needed as well. And most people take TB medicine for at least 4 months to be cured. We had a question in the chat and I answered it, but I just wanted to bring it up. So the question was, how effective are TB vaccines? And I just wanted to share that TB vaccines are highly effective at protecting against severe forms of TB in young children. And BCG is widely used in many countries with high TB rates to protect young children, but it doesn't reliably prevent TB infection or pulmonary TB in adults. And researchers, and that's why it's so why there's a lot of education needed and support and funding and advocacy needed around advancing new diagnostics, working on new TB vaccines that can offer better protection for all ages. Okay, next slide. People vaccinated with BCG can still get TB disease. So as I shared, BCG is a vaccine for TB disease. It's not widely used in the US. It's often given to infants and small children in countries where TB is most common, and it protects against severe forms of active TB in children. Protection from TB goes away as people get older. Next slide. Treatment for inactive TB. I think I shared this one. So next slide after this. Okay, next slide. I think it's a copy. And then the next one. All right, so there are 2 forms of treatment. Directly observed therapy, which is the most effective strategy for ensuring that patients stay on track with their treatment. So what happens is a healthcare worker will meet with the patient to watch them swallow each dose of the prescribed drugs. And then during DOT visits, a healthcare worker will check in with the patient to answer questions, make sure the treatment is working, and watch for side effects. Next slide. There's also video DOT, and so and that's another approach that is similar and a little bit more accessible, that is helpful as well. And many times, I think when a person who is going through treatment for TB, they experience a lot of I think isolation and loneliness, and it's quite challenging. And so there's this effort that I think is really important around the kind of feeling of togetherness around bringing people together. And so that's why I was sharing the organization earlier, We Are TB, because what they do is they bring, you know, current TB patients, past TB patients, survivors of TB, however these folks want to identify themselves, together to bring support during this time, because it can be a really isolating and difficult time while going through treatment. And so what some of the efforts that we're moving forward and towards around TB, and I just want to uplift these 2 points because they're pretty critical to what the TB Elimination Alliance does, and then kind of goes back to what Hep B United does around strengthening. For TB, we're strengthening, our focus is to strengthen current TB programs to diagnose and treat TB disease. What the TB Elimination Alliance does is we really want to be that liaison between the TB programs with the community health centers and the CBOs, and making sure that there is that strong connection of the community that is represented. And then we want to increase efforts to identify and treat latent TB infection and active TB infection. And so next slide. And just wanted to share some more resources here, but before I think get into some of these other sides, maybe I can just like bring it to Frank to share some other, if there's any additional kind of resources on the Hep B side around I think how healthcare providers and communities are working together. And I know that you all are doing that constantly through all of the rich, I think, resources that you offer, I feel like daily, which is just so helpful. So again, uplifting Hep B United's website. I always go to it for some additional resources, but yeah, I'll bring it to Frank to share a bit more, and then I can share some additional resources on the TB side.
Yeah, so I did put both of our websites, the foundations and the coalitions. Both are a wealth of information, both in terms of text and then videos, graphics, recordings of webinars and other deep dives, as well as linked to journal articles. I would say for Hep B United, we are more focused on the organizations that are providing services to the ground. So a lot of our resources on the resource repository are in non-English languages and are written in a way that is geared towards community health workers as well as other CBOs and then people like in the community. And then on the foundation, because we do have such a strong public health research side, that is where you will find some of our either links to or our own materials on treatment guidelines, things that are more clinical or scientifically focused, as well as resources that really just resources for if you are a clinician or a scientist. So we really do run the gamut of accessible materials, and our foundation websites, the entire website is in 16 different languages. So we really do try to make our items accessible for all of those communities that need it.
Thanks, Frank. And just sharing, healthcare providers and communities similarly to Hep B need to be thinking about TB and thinking about Hep B. And so it's a lot also making sure that we have these resources available and that our healthcare providers and communities know how to tap into these. And next slide, just wanted to share, I think a little bit more for the Think, Test, Treat resources. I think you'll all be able to get these slides later, but these are additional resources. And, these key partners in TB elimination are also key partners in Hep B. And that's, I think, a lot of the reason why we have these syndemic challenges and approaches and experiences, because we are, though it's different, there are similarities in many ways as well. I think we can close down the slides, and Brennan, I know we only have like a minute. I think time went by so quickly. But I know that we've been answering a few of the questions and answers in the chat, and I'll bring it back to Frank or Shreya if there's anything else that you wanted to add. But I just wanted to say thank you for letting us be able to share more about the TB work and this connection and importance of us having some more dedicated time to talk about TB and Hep B together.
Yeah, so we actually have a question in our Q&A, and this is a Hep B question. So, discordant couple, meaning one person has the virus, the other one doesn't. Essentially, is it safe to have kids, and can you still have a loving relationship without risk? And the answer is yes. The biggest pieces there are, one, the individual living with the disease, if they are able to access care and get onto treatment to bring their viral load down, that will help. But even outside of that, there are things that the negative partner can do, like being vaccinated is absolutely the biggest one. So getting vaccinated, as well as some other just ensuring any interfamilial transmission doesn't occur. So like not sharing nail clippers necessarily, or like just being extra safe, if the negative person's unvaccinated, being extra safe in case of, a blood accident, like a knife or something with their positive partner. And then in terms of preventing perinatal transmission, you noted that the person who would be pregnant is the negative. That should be fine as well. But even if not, if it was the pregnant person was positive, we do have that HBV prophylaxis dose that is able to be given to newborns that really does help prevent that disease. So yes, we are to a place that even without a cure, we have pre and post prophylaxis, we have preventions, and we have treatments that can have a discordant couple like that not transmit in our family and keep everyone safe. So thank you for that question. That's actually a really good one, and one that I just love to be able to be like, yes, you can still live your life like everyone else, and because that is where we're at with the science.
Well, thank you both for that insightful presentation. We didn't have as much time dedicated to the Q&A as we thought, but if you have more questions, please feel free to email them to us and we'll get those answered when we get the slides to you. And I hope all of you found the presentations today insightful, and hopefully it's helpful for you and your programs. If you have questions about hepatitis B or TB or about Hep B United or TB Elimination Alliance, please feel free to reach out to us. Frank and I are on the Hep B space, and Chibo, Dia, and Rihanna, who are present for today's session, are on the TB side. So please feel free to email any questions or concerns you have, and we'll be more than happy to chat with you. And thank you so much, everyone, for joining, and we'll see all of you soon. Thanks. Have a good day. Bye.
Thanks. Bye.